Troponin tells you about myocardial injury and not necessarily always myocardial infarction. Here are 5 clinical scenarios where you get troponin elevation and that doesn't necessarily mean there is myocardial infarction. Tachyarrhythmias. Following tachyarrhythmias like AF with FVR and supraventricular tachycardia, there is myocardial wall stress, and this can lead on to leaking of troponins into the blood and elevated troponins. But these usually settle with resolution of myocardial tachyarrhythmias. Heart failure and hypertensive emergencies are associated with myocardial wall stress and leaking of troponins, but not necessarily myocardial infarction. They may produce reasonable elevations in troponins. Septic shock is another condition where you can have metabolic dysfunction, microcirculatory failure, and even type 2 myocardial infarction. And this can lead on to troponin elevation, but they usually settle by the time the sepsis is controlled. Chronic kidney disease, definitely there is reduced clearance of troponins through the urine, and also the hypertension associated can increase the myocardial wall stress, and these can produce troponin elevation. So trend the delta troponin, not the absolute values of troponin. They help you in distinguishing coexisting myocardial infarction when you're suspecting one. Pulmonary embolism is another condition where there is RV wall stress and troponins are frequently elevated due to the stress, not necessarily infarction. And this troponin elevation roughly correlates with the severity of pulmonary embolism actually. So bottom line is that troponin elevation doesn't mean myocardial infarction always. Look for the clinical context, interpret with ECG, concurrent patient symptoms and risk profile. Think wise, think physiologically.